Well, good morning, everyone. I know it's early. I just want to thank everyone for coming to this early session, this early Sunday morning session. For all of those in Eastern Canada, I don't feel sorry for you. For those from Vancouver, I know that there's something for Vancouver here. It's 3:30, so yeah, I'm going to go back to bed after this session. In any event, welcome to the New Development in the Management of Advanced Prostate Cancer Impact on Cancer Care in Canada Symposium. This is an accredited event. It is broadcast via WebEx, so there are actually people online. Now, I would ask if there are any questions that you go to the microphones, and I will be asking and polling the audience as well. So I'll be summarizing all of the questions if you're not on a mic to the WebEx people. And again, for those urologists who are wanting credits, you have to have registered, and if you're not registered, your name needs to be up on the front in order for you to get credits. It's my pleasure to introduce the faculty. Of course, this is not working. Great. So from Vancouver, we have Dr. Kim Chi, medical oncologist, BC Cancer Institute, Dr. Fred Sod, uro-oncologist from Montreal, and again from Vancouver, Alan So, myself, and I am a urologist. There are our pertinent disclosures. These are just some standard slides for accreditation. All faculty have adhered to various different code of ethics, etc. This is an accredited CUA program that has received funding from Janssen. And again, for those who are wishing credits, please contact Melanie Rose if you have not received them. It is automated, so you should be receiving your certificate via email or mail. But again, if you have any questions, you can email Melanie Rose. So here are the learning objectives. I think this is a really interesting situation that we have right now, in which not only do we have a tremendous amount of data in castrate-resistant prostate cancer, but we're now opening up the spectrum and not necessarily forcing the issue amongst urologists, but making it more important for urologists, in my opinion. And obviously, these two studies that came out at ASCO called Latitude and Stampede will be at the forefront. But before I go on to that, we're going to be discussing as well the role and impact of the various data as it pertains to us right now. So we're going to be looking at CRPC in the metastatic realm, and then advanced prostate cancer in terms of the paradigm of treatment from hormone-sensitive disease and maybe even M0 all the way up to the development of CRPC. So those are the first two objectives. Again, we'll also identify clinical trials of prostate cancer that may shape future changes in the management of this disease as well. Here's the agenda. There'll be two cases, and again, the two presentations will be shaped around two cases. We'll have plenty of time for questions. I hope that this is very interactive, and I hope that all of you who have questions come and ask. I'll be polling all of you as well, so again, please don't be shy. So let's start. The first case is a 69-year-old gentleman who has very little comorbidities, mild hypertension, elevated cholesterol, a typical 69-year-old. He was diagnosed in 2016 with very aggressive and advanced prostate cancer. So he had lymph node disease as well as non-visceral metastatic bony disease. His PSA was 560 and 5, showed Gleason score 9. At time of diagnosis, he was started on maximum androgen blockade. The PSA initially majored only to 10, which in itself is a bad prognostic sign, and unfortunately, very quickly became castration resistant to 12, 18, and again, with a very fast upping time of, if you can believe it, less than a month, all the way to 52. The bicalutamide withdrawal did not help. So fortunately, he has only very mild symptoms. The pain is relieved with acetaminophen and ibuprofen. The bone scan that was repeated did show multiple bone metastases. The CT scan continues to show lymph node disease, but no visceral disease. So for the audience, how many here would just observe and watch? How many here would give them some form of steroids? I know that in some parts of Canada, dexamethasone challenge of 0.5 milligrams is often used. Would anyone here use dexamethasone? Or no? Or any other hormonal maneuver? A re-challenge with bicalutamide? No. How about abiraterone or enzalutamide? Great. So for those on the internet, there were 3 out of 100. Radium-223 and docetaxel. So 3. So 3. So the rest are, I'm not sure what they're doing. So I'm going to start off with Fred. The CUA guidelines would suggest that in this patient who is mildly symptomatic, 3 and 5 are appropriate, but let's assume he was very symptomatic. Would that move you away from Abirenza towards Dosi?
So in a patient like this, clearly Abirenza would be the first choice, and that's in the guidelines, and I think it's what we do in clinical practice. Now, in a very symptomatic patient, it will depend on the patient. So a young, healthy patient who's very symptomatic, able to tolerate chemotherapy, chemotherapy would be a choice that we would discuss. Now, an elderly patient where I'd be worried about the effects of chemotherapy, then I would likely try the hormonals, knowing that these patients have a tendency to respond sometimes less well, but we do have very nice responders.
I always give abiraterone as my first line. I never go up from the chemo. I know we talk about that sometimes for patients with aggressive disease.
What about a lot of visceral disease?
This one, I still give abiraterone as my first line because you can see dramatic responses in either case. We do have a randomized trial that we're doing now, taking patients just like this, randomizing them to receive either abiraterone or enzalutamide versus taxane chemotherapy. That should be out at the end of this year.
So this is the world upside down, right? So the urologist is pushing for chemo in the medical culture.
Oh, that's for you. Yeah. And I guess my last question before we go into Kim's talk is, would either of you give some type of hormonal maneuver here with dexamethasone or prednisone in the Abirenza era?
No, I don't. There's no phase 3 evidence showing survival. You have 2 drugs, 3 drugs here. You can even put 4 drugs of radium that have shown improved overall survival. So playing around with dexamethasone in a guy that has pretty aggressive disease, I wouldn't do that.
Yeah, clearly no.
Okay. And interesting, there is an ASCO consensus paper actually that came out last year that says that secondary hormonal maneuvers are not appropriate in men with metastatic cancer-resistant prostate cancer. I agree. I think number 2, number 1 are wrong.
Yeah, and beyond the steroids, the whole issue of re-challenging with another first-generation anti-androgen, I think, is a waste of time. It can actually be dangerous of trying those maneuvers in a metastatic state like this patient.
No, I'm